Welcome everyone. Let me introduce my PhD thesis topic, which is the importance of pancreatic exocrine insufficiency in pancreatic diseases. My name is Orsolya Eperjesi. I am a third-year internal medicine resident and a second-year PhD student. My vision is an early diagnose and appropriately manage pancreatic exocrine insufficiency across pancreatic diseases, and to achieve this, my mission is to optimization of pancreatic enzyme replacement therapy in acute pancreatitis patients. For these goals, I have 3 ongoing projects. My first project aims to investigate the predictive risk factors of pancreatic exocrine insufficiency and the effects of pancreatic enzyme replacement therapy after acute pancreatitis. Why this topic is important? A previous meta-analysis demonstrated that the prevalence of PI during an AP hospitalization can be as high as 60%, and although this frequency falls during the follow-up, persisting in a minority, and the PI prevalence is still about 30% after a 3-year recovery. So there is a high prevalence of PI in patients with acute pancreatitis, both during their initial hospitalization and in the long-term follow-up. And untreated pancreatic exocrine insufficiency can cause several intestinal symptoms such as abdominal pain, bloating, cramping, increased flatulence, diarrhea, and diarrhea. And all these pathological changes seriously affect the quality of life of patients with pancreatic exocrine insufficiency. However, the diagnosis of PEI can be challenging because the PEI symptoms are non-specific and the diagnostic tests are not widely available. And therefore, identifying high-risk patients is highly important to avoid misdiagnosis and delayed therapy. Therefore, we aim to identify the risk factors of PEI and investigate the effects of PERT in acute pancreatitis. We asked the question, what are the rates and the predictive factors of PEI in acute pancreatitis? We used the COCOCOP and the PFO framework, and we hypothesized that the rate of PEI symptoms is increased among patients with acute pancreatitis, and there are risk factors that can predict PEI in acute pancreatitis. We conducted the systematic search within 3 databases, and after the whole selection process, including the citation chasing, 54 articles were eligible for systematic review and meta-analysis. Let me show you some of my results. On the first plot, you can see the proportion of PEI at discharge. The overall measurement of the proportion is 0.64, meaning that 64% of AP patients have PEI at the time of hospital discharge. We also investigated the rate of PEI during the AP follow-up. On this plot, you can see results for the first-year follow-up, and however, we can recognize some recovery in the pancreatic function here. In around 20% of AP patients, PEI is still persists. This is important because, as I mentioned before, untreated PEI can cause several intestinal symptoms and leads to malabsorption and malnutrition. We also wanted to see which factors can affect the PEI development after acute pancreatitis. Therefore, our next outcome is the odds of PEI development. And here we are comparing patients with alcohol-induced AP to patients with biliary AP. And based on our results, having alcohol-induced AP is associated with a 2 times higher risk for PEI development. However, this result doesn't reach the statistically significant level yet. On the next plot, you can see results for the same outcome, the odds of PEI development. However, here we are comparing patients with severe acute pancreatitis to patients with mild acute pancreatitis. And the odds ratio is 2.59, meaning that the odds of PEI development is 2 times higher among patients with severe acute pancreatitis. Furthermore, we investigated patients who underwent necrosectomy compared to patients without necrosectomy, and our result shows that the odds of PEI development were 3 times higher in the necrosectomy group. Last but not least, we wanted to see whether the patient gender can affect the odds of PEI development or not, and based on our results, there isn't any connection between the patient gender and the odds of PEI development. Our study have some strengths and limitations as well. The strengths of our study included that we can provide evidence-based recommendations for PEI, monitoring after acute pancreatitis. We use the robust scientific methodology and we have clinically relevant subgroup analysis. However, the meta-analysis was limited by the fact that the outcomes definitions were varied among the studies and they have checked the outcomes at the different time points. In conclusion, our results shows that more than half of the AP patients have PEI at the time of hospital discharge and quarter of them during the AP follow-up. Moreover, severe acute pancreatitis and necrosectomy are associated with an increased risk for PEI development. Based on our results, we can recommend screening AP patients for PEI after acute pancreatitis, and early PERT administration should be considered in case of severe acute pancreatitis and after necrosectomy. As regards the implication for research, further research needed to investigate the role of infection in PEI development and the effects of PERT in acute pancreatitis. Our manuscript is submitted to the UG journal. Let me introduce my second project a little bit, which aims to investigate the risk factors of calcification in patients with chronic pancreatitis. Pancreatic calcification is the most frequent structural change in chronic pancreatitis, and those patients who have calcification in the pancreas more likely to have severe abdominal pain, more often need hospital admission or even surgical treatment. Less is known about factors associated with calcification in patients with chronic pancreatitis. Therefore, we aim to investigate the risk factors of calcification in patients with chronic pancreatitis. We asked the question, what are the risk factors among patients with calcifying chronic pancreatitis? We used the PFO framework, where the population were patients with chronic pancreatitis, factors were any risk factors that we could identify, and the outcomes was a pancreatic calcification. And we hypothesized that specific risk factors can predict the calcification development in chronic pancreatitis. And by identifying the modifiable risk factors, we may help prevent or at least slow the progression to calcification. We conducted the systematic search within state databases. We used the search key that you can see on the slide, and we ended up more than 80 articles. Let me show you some of my results. Our main outcome was the odds of calcification development in chronic pancreatitis, and here we are comparing patients with alcoholic chronic pancreatitis to patients with idiopathic chronic pancreatitis, and our result shows that the odds of calcification is higher among patients with alcoholic chronic pancreatitis. We also investigated the role of some detrimental behavioral factors in calcification development. And here we are comparing CP patients who were drinker to patients who were non-drinker. And our result shows that the odds of calcification were 2 times higher among patients who were drinker. On the other hand, we were investigating CP patients who are smoker compared to patients who are non-smoker, and the results is the same. The odds of calcification development were 2 times higher among the smoker. Here you can see my second project progress. We finished the data extraction. Currently we are working on the risk of bias assessment, and I also started the manuscript writing. As a summary, I have 3 ongoing projects. My first manuscript is submitted. The second project is in the article writing phase. And the third project will be a register analysis where the extra data extraction is currently ongoing. Thank you for your kind attention.
Thank you very much, Orsolya. It's interesting results, and I was a little bit surprised that more than 60% of the patients have PEI in your study. What was the method the PEI was measured? That's my first question. And the second, that do you have any data that in which patient did the PEI improved during the follow-up, because it dropped down from 60-something% to 20-something%.
For the first question, different diagnostic methods were used to diagnose PI among the articles. This is the reason the high heterogeneity. So, but the most common diagnostic test was the fecal elastase. And I am not sure I understand well your second question. So it was regarding the improvement during the follow-up.
Yeah.
What was the reason?
Or do you have data at the end of the follow-up? So after 1 year of the acute attack, what was the distribution, for example, severe acute pancreatitis and mild acute pancreatitis in patients with PI, or so do you have any data about this group of patients?
No, unfortunately, we didn't investigate this, but we think that I think the reason behind the improvement is the resolution of the inflammation. So
definitely, but it would be good to know in which patient can we expect the resolution.
We didn't examine this regards.
So, is there any question from the floor?
Thank you for your presentation. I would like to ask that what is the clinical benefit of your second project?
Well, as regard implication for practice, I would say that as alcohol and smoking are a significant risk factor for calcification, it is crucial to identify these risk factors in the affected patients and incorporate alcohol and smoking cessation program as a part of treatment.
Thank you.
Are there any other questions from the audience? I have one question related to your first project. Congratulations, by the way, for both, because both of your projects are in a really, really advanced phase. So for the first one, are all of these patients after their first attack of acute pancreatitis?
Yes, we excluded patients with recurrent acute pancreatitis.
And what is happening on that forest plot where you show the symptoms of PEI? There are some studies where only a small percentage of people experience this, but in another study, all of the patients had symptoms of PEI. What was the difference between these groups, or articles at least?
Which plot?
I think the first one where all of the patients, so
44
at
the time of discharge?
Yes.
I think maybe the AP severity can be the reason.
And what specific symptoms were reported in these studies?
Abdominal pain, diarrhea, and stertorrhea and weight loss was the most common symptoms.
Okay, thank you, Orsi.